Guys, I just did an amazing podcast with April Patterson, a friend of mine who's a pelvic floor physical therapist that specializes in pelvic floor PT, especially for patients that have persistent genital arousal disorder. And she talks about her journey with PGAD and also talks about her treatment strategies as a therapist. And so you guys are going to really enjoy this one. And I hope you learned something about how to advocate for yourself through this educational journey. Thanks. Hey, y'all, it's me, Dr. Smina Rahman, Gyno Girl, back for another episode of Gyno Girl Presents Sex, Drugs, and Hormones. I am super excited today. I have a friend of mine here on the show who we befriended many years ago at ISHWSH, the International Society for the Study of Women's Sexual Health, which you hear me talk about all the time. But we're going to today talk about persistent genital arousal disorder and, what that is. And, we're going to learn about April's story. So today I have April Patterson. She is the owner of Whole Body Physical Therapy in Studio City, California, which is a private practice that specializes in pelvic health physical therapy for all sexes and genders and gender identities. She has been a physical therapist for 20 years, practicing in orthopedics and sports medicine for the first 9 of her career. And then she shifted into pelvic health 11 years ago after the birth of her second child. Her passion for pelvic health began long before that through her own journey in healing and managing persistent genital arousal disorder or genital pelvic dysesthesia symptoms. She was symptomatic for 13 years before she underwent spinal surgery in 2017, which set her on the path of permanent resolution of her symptoms. She is a member and expert on the ISHWSH Consensus Panel for PGAD and co-authored the ISHWSH Process of Care paper for the management of persistent genital arousal disorder and genital pelvic dysesthesia. I use this every day when I see my PGAD patients. I show them this, actually. I show them the process of care. I'm passionate about pelvic floor therapy, but also about PGAD. And so this is really an amazing opportunity for us to learn not only more about PGAD, but about specific journeys so that we can all learn how to advocate for ourselves like she did. Thank you, April. Welcome.
Thank you so much for having me. I'm thrilled to be here.
Awesome. So I just want to first explain, a little bit about what persistent genital arousal disorder for the viewers. For the listeners who actually are not familiar with it. And just in general, it's considered a condition where you have an unrelented, sort of unremitting sensation in the genital pelvic region. And it's associated, and it's potentially these feelings of arousal without thinking about sex or wanting to have sex. And so it's associated with significant psychosocial impact on patients' lives. I know from the patients that I've treated, there have been patients that have been suicidal with this, that have been dealing with it their whole life. It's extremely misunderstood and understudied, just like most of sexual health. I think the first case was reported in 2001. And really, we have a process of care of how to treat patients for this. And I'm going to let April get into this a little more detail, but essentially we do it based on the regions that we think are most contributing to this neuropathic pain syndrome for the most part. And we're looking at either the end organ, which is considered region 1, and that could be your clitoris, that could be your vulva, that could be your vulvar vestibule, that can be, your bladder. And then, it could be related to vestibulodynia. It could be related to vulvar dermatoses. It could be related to clitoral pain and adhesions. And then the region 2, which is the pelvic floor and the importance of that musculature. Region 3 is considered the cauda equina, which is the convergence of all your spinal nerves at the end of your backbone, the end of your vertebrae. And then region 4 is considered the lumbar sacral area, so your spinal cord, again, a little bit above the cauda equina. And then region 5 is your brain, so if the signal is believed to be coming from the brain. So these unrelenting feelings can come from any of those. It can come from the nerve endings, it can come from the nerve roots, or it can come from the brain. Remember, we talked about this in the podcast about clitoral pain, but obviously, remembering that our central nervous system is composed of both our brain and our spinal cord. So these areas communicate with each other. They send signals down the spine to your peripheral organs, to your end organs, and this is how our nervous system communicates. And sometimes when it goes a little out of whack, it can create very distressing symptoms, whether or not it's just regular pain, whether or not it's burning, whether or not it's symptoms in the area where you have erogenous tissue. And that's what we're going to discuss. So, April, I actually met April for the first time at Ishwish, and I remember hearing her compelling story when the link between the spine and, I like to say I was almost in the room where it happened, but I wasn't in the room where it originally happened, which is where but I was almost in the room where it happened because I heard, her tell her testimony to the International Study of the Women, a study of women's sexual health, and all the providers that came from all over the country and the world. And so she was very brave. My first podcast, I asked, am I brave or am I shameless for doing this podcast? But I might be shameless, but you're definitely brave. So I appreciate you coming on the show. And then, please tell us how you knew you something was wrong, when it came about, and sort of your journey into self-advocacy.
Thank you. Thanks so much for saying that. Well, my overall, it was really an orthopedic injury that eventually reared its ugly head and progressed into something where most of my symptoms were in my pelvis. I'd say, well, I was a college soccer player, and I wasn't
That's
back
amazing.
back.
Tell me what was your role in soccer?
I was a
The
left
position.
defender. I was a left back. I
Oh,
also was a figure
nice.
skater growing up. So I had
Yes.
back pain most of my life. I put my back in pretty extreme positions. And I think just the mentality of an athlete, especially back in the early mid 90s, you just went back out there. So I was always, playing hurt. It wasn't, and I was cleared by my athletic trainers. I had, they diagnosed me with SI joint dysfunction. All my symptoms were always on my left side. It was very eerie eventually when things progressed so much, because it was like one half of my body was completely different than the other side of my body. And it was just very strange. But that's what I knew. And I'd say I started having persistent genital arousal symptoms. It wasn't distressing yet, where I would say it was a disorder. I just noticed sitting in class in college, it would take a certain amount of time. Like if I were studying in the library after, a couple hours, I'd be like, what is that? What is that? It didn't distress me. I was like, maybe I'm bored. I'm daydreaming, or I would walk, I'd leave, I'd be gone. And at the time, I was dating, who's now my husband. And when we would have intercourse, I'm just going to go right there right now. We would have intercourse, and from deeper positions, it would cause this pain in really deep, in my left, I call it my left corner pocket back then. It felt like I was getting socked in my spine, and it felt eventually he was hitting my sciatic nerve, and I would start to get leg pain, and I'd start to get a burning, but deep nerve pain in my vagina. And eventually it would just go away. And fast forward, and I would sort of clench around that. And so, and, we communicated, but I was 21 years old, and I mean, you don't really know at that point. And, the PGAD wasn't even mentioned yet in the literature. There was really nowhere for me to go, and there's no one I told about that. I didn't even know anything about that. So, um, and then by 2008, I was an ortho PT, and I'd run on my lunch breaks. And all of a sudden, on my runs, I would get this same burning vaginal pain. And I was like, this isn't right. Something's wrong here, because why would I feel my sex symptoms when I'm running? And that already is it's not coming from your vagina. It's, maybe there's a polyfloor problem. The forces change when you work, when you work out, things change. I wasn't familiar with pelvic floor physical therapy. It definitely piqued my interest of how am I going to fix myself? Who am I going to go to about this? So my coworker's wife was a pelvic floor physical therapist. So I started going to her. And then eventually I found someone who was my person, who really worked with me through some of my worst years. And she could sort of get me back to what a baseline was, so I was functional. through my pregnancies. And I mean, those were really hard, especially my second pregnancy. And as you know, after you have a baby, it's like, I mean, I had no core left. Like my spine was, it just, I think that was like the nail in the coffin, so to speak. That's the second carrying of the baby, just like my spine just never really recovered after that. And my symptoms at that point, postpartum, and again, this was slow. Like this took time. Like I had left hip pain, burning in my hip. Oh, you have piriformis syndrome. No, I don't have piriformis syndrome. Like I had things that, I mean, nothing, I never really fit into any box. I thought maybe my skating, the way I was one-sided and always tilt, like maybe I actually did have a pudendal nerve entrapment. But the amount of different nerve sensations that I had pretty much all the time, and that at a lower level, that once I sat down would just shoot through my body. I had the PG, the persistent arousal. I had shooting into my hip, which felt like was going to the spot in my vagina, stabbing in my rectum. Eventually, I was getting twitches. Like it just would, it was a neuromuscular problem. I was getting fasciculations in my pelvic floor, in my rectum. And over time, I sort of learned little tips and tricks to keep me functional and get through my day. But by the end, I mean, nothing could touch my pelvis. I was so sensitized. If anything, like
Mm,
anything just sat it would just immediately shoot. And it was like the whole nerve pathway. Like if you go look
yeah.
at the anatomy from, I had an L4-5 disc surgery. If you look from there down, it was everything. It was my cluneal nerves. It was everything. Like this is not pudendal
Interesting.
neuralgia. And so
Yeah.
I didn't tell anybody. I didn't,
Yeah.
my husband knew somewhat,
Yeah.
but I didn't ever go see a professional at that point. I didn't tell my
Yeah.
gynecologist who's delivering my
Yeah.
babies. Like
Yeah.
I didn't know. I think being on the other side of things, I thought they would tell me you're crazy. They would look at
Mhm.
me like
And many
um,
of them say that to
and
patients,
they
you know?
do. And I know
Yes.
that because I see
Yes.
people with pelvic pain and I'm like,
All the time.
like I I don't want to be in the other end. I was highly anxious and I that would have been devastating to me. So I just avoided it altogether. I don't recommend that, but I do think at the time I really didn't have an option. Like I didn't have, there really wasn't anyone who, um, was doing this research. Like it was not as well known as it is now, and it's still not well known. So um, I didn't wanna be the crazy one. I didn't wanna be the crazy patient. I didn't want them, and I had to, towards the end, when I finally started getting help, I had to go get an X-ray of my spine. How was I gonna get that approved? I had to be honest. I had to be vulnerable. I had to tell. I sat in a room with these like, intake sporty looking people and they were like, "Okay, where's your pain?" And we looked at the dermatome diagram and I pointed to like S3, S4, S2 and they were like, "That doesn't make any sense. Like you don't make sense." And everyone would tell me
Right.
that. And then the doctor would be like, "I think this is from when you delivered your baby." And I'm like, "I had 2 C-sections." Like,
You didn't even
um
have labor, right?
I didn't
Yeah.
have, it didn't tear, it's
Yep.
not, no, and they
Yeah.
were just like, and they sort of just looked at me, and this was a place I took my kids to, that's where
Yeah.
they had their sports injury, and I was like,
Yeah.
"I just need that, just give me the MRI."
Yeah.
Because
Let me just be out of pocket at this point.
just give me the MRI, right? And so
So
and that was when I really, we got the ball rolling. But before that, I'd say when I was at my like worst,
Mhm. Yeah, what was your tipping point? Because obviously you'd been struggling for a while, you found
yeah.
ways to kinda deal with it, maybe arousal got better sometimes with sex, maybe it didn't,
Mhm.
but everyone has a tipping point at some point,
Yeah.
right? Like, that they'll feel like and
Right.
I think what's interesting is you and I are both in the medical profession, we both had issues, and I talked about vaginismus for myself, but it is this whole, like, idea that, how are we gonna present ourselves to somebody and it's this idea of like, "Okay, are they gonna be like, 'What's wrong with, this other medical professional?'" You don't you
Yeah.
feel like, I don't know, you try not to make yourself that vulnerable, I guess.
I
But
felt like I didn't have a voice, like, I couldn't
yeah,
speak up. I felt like I couldn't speak, and so I just stayed quiet. And a
right.
lot of this was really, through my healing when I did get the care I needed and I did, find solutions. it was very emotional, and it was very,
Oh, I bet.
I really changed. I evolved as a person through all of this because I came out the other side, but also, um, I had to learn to create. Like, I was just so used to just putting up and being in pain, and,
Yeah.
um, I had to make in order to heal well, I had to put myself first a lot. I had to, I have 2 little kids.
Mhm.
I had to really create the boundaries for my health and healing, which I think too, even with our own patients, like you just wanna be the person you were. You wanna be that, like, I used to do everything, and now I can't, and who am I? And who am I? And it doesn't mean I won't get back there, but, I really struggled with, like, just when things were bad, when I was at that tipping point, who am I? Like, I don't know my role anymore in society. I'm a mom. I can't pick up my kids. I can't sit on the floor with them. I have to say, "Oh, mommy's back hurts all the time." When is mommy's back gonna get better? Yeah, it was very emotional. And even just within the marriage, in my relationship, I am a doer. I could go, 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 push, push, push. Push isn't great. Push is not good for you. Push is balance is really what we should be striving for. But I had to really reprogram what, like, this is what I need, and these are the things I need. And how am I gonna change my life and my lifestyle so that I can get better? Because it's not a quick fix. Surgery was amazing. Without it, I would not be better. I would not be better. I needed that surgery, and thank God I had that surgery. Like, but I really had to reevaluate my entire life and how I was living, and make it so I could heal optimally and just take care of myself in every aspect. And really, that's how I was there for my kids and my family in the long run. Um, so at my tipping point,
I'm sorry that you struggle like that, but this is actually a very common, unfortunately, we see the
yeah,
patients like this all the
yeah,
time, right? That
yeah,
are trying to do everything for everyone, but then at the end of the day, they can't make time to take care of themselves. And then eventually everyone hits a tipping point. Like, all
yeah.
right, if I don't do this, then no one in this
We're
whole
like,
sphere I'm in are going to be
yeah,
able to function, right? So
exactly.
what
And
was your tipping point?
I remember being so sad, like, just so, um, I don't know what I'm gonna do from here. I am becoming
Right.
disabled.
Yeah.
And
Yeah.
this isn't who I am. This has never been me. So tipping point, I mean, the pain was atrocious. The
Hmm.
arousal was atrocious. So the way it feels, at least for me, I know it's a little bit different with everyone. Like, some people have an orgasm, they'll get a little bit of temporary relief and then it comes back.
Hmm.
Every time I sat down, which is, similar to, like, they say, "Oh, that's similar to pudendal neuralgia too. When
Right.
you sit, pain
Right.
with sitting,
Yeah.
it's one-sided." But mine was my entire leg, and, like, sciatica would go numb. And then, like I said, I had many different nerve pathways that felt like many peripheral nerves were affected, even though there was coming from upstream. So, but the orgasm piece, it went from, like, it used to take me, I remember in, like, 2013, when I started, like, I had my second kid, I started, like, driving further. And then I was working about a 40-minute drive from where I dropped off my first son to preschool. And that drive to Santa Monica was brutal. Every single time I drove to work, after about 20 minutes, that was sort of when things really kicked in. I would start having the throbbing pain in my genitals, like I'm building up to an orgasm. And I would eventually, like, if it were an hour, I would have to pull over. I would be having these involuntary contractions that would lead to orgasm. And, like, this is not, I'm just trying to drive to work, like, and it hurts. It was never
Didn't make anyone
pleasurable
orgasm.
for me. Yeah, I know. I'm
Mhm.
like, I'm like, exit now, like,
Exit
drive
4 or 5.
someplace that's, like, maybe no one can
Mhm.
see. Like, and
Right.
then I'd park and I'd walk to work, and my leg would
Uh-huh.
be, like, throbbing to my genitals. And then by the
Oh,
time
wow.
I
Mhm.
walked for about, like, 10 minutes, I'd walk from my
Mhm.
car to work. I was okay again. Like, not okay, but I was at my baseline again where I could do my
Mhm.
job. And um so that's sort of how the organ, and then, with my partner, um, though that position that originally started the sciatica, that became a no gamer, like, between even my pregnancies, like there was no rear entry, no deep, nothing of that sort, or I would be in tears. And it would make my symptoms worse. So our sex life definitely evolved over time to like, we can't do this, we can't do this. We can do it this way. This is something I can do, but even just with like self-stimulation, masturbation, like I used to be able to have a little bit of relief and then it would come back. But like now I almost couldn't peak and climax. Like I almost couldn't climax. It was almost like I became, even though I was hyper aroused. My motor function had changed. Like my actual orgasm had changed and it was dull. I couldn't get over the hump. Like I just couldn't get there. It would take longer. It would hurt. And it was like, what do I do? Okay. Like I was just in this in between zone all the time. And then when I sat, it was just like blew up. So by
Right.
the time that wasn't even like really my rock bottom.
Yeah.
The
But that
rock
was
bottom.
getting there, right? That
The
was getting there.
second I sat down in the car, my kids are in the backseat crying, like, just like, let's go, mom. And I'm like, eh. And like the second I sat down,
Oh,
it was just
yeah.
searing and it was, I was shifting to my side. I tried the donut cushions, like
Yeah.
nothing was enough. And then it's like, oh, mom can't drive us anymore. Oh,
Mm,
I'm avoiding going to dinners. I'm avoiding being social. I'm avoiding
mhm.
meeting with friends I used to enjoy. All the things we would do at our school, it was like, what time is that? Because by the end of the day, it was pretty bad. Yeah. By the end of the day, and they'd run and jump up to me. And like, I used to be an active person that played with my kids. And it was like, I was a shell of myself. I was like, didn't know so that was, I don't know what I'm going to do. Something
Did
has
you
to
find
change.
yourself did you find yourself catastrophic? Because I have a lot of patients who either had anxiety that might have, promoted this, or, like, it contributed to this, and then, or they develop anxiety because they catastrophize about this is, especially if you've struggled so many
Yeah.
years, you feel like this is never going to go away. And I
Yeah.
think that then leads to, more anxiety, more depression. And
Mhm.
that's why, unfortunately, there are PGAD victims who will actually, attempt to take their life because they've been dealing
Yeah.
with this for so long. And
Yeah.
that's some of the most compelling stories that we hear, I think, is that, like, and what an amazing
I
thing
was
for patients when
there.
they see
I was
you. Yeah,
close. Yeah. I mean,
really.
I definitely I didn't have suicidal ideations. I didn't have anything
Right.
like that. I, I really started to feel like I knew, I'm like, this is only getting worse. I could always
Mm,
keep it where I was functional, but
yeah.
this is now gone over and I
Yeah.
don't know how I'm going to get back. And
Hmm.
I had taken a trip around that time. It kind of crazy when I look back at it. Like I did a backpacking trip
Oh, wow. Oh my
and I
God.
went Spain with my husband and I bought a
Yeah.
backpack and I remember going to REI and like was almost in tears. I probably seemed like such a bitch. Like they were like, what's wrong
Uh-huh.
with that lady? Because I
Uh-huh.
was
Uh-huh.
nice about it, but I was like,
Yeah.
I can't use any of these backpacks. Nothing could touch my pelvis. Nothing. So I got a special order one that only went to my thoracic spine and I would carry my stuff that way. And the flight back from Spain was was the worst thing ever. And, I didn't have like business class. I was in like economy. um, and, and, that was sort of like the end. When I came home, that was October 2016. And then I want to say in February of 2017 is really when my life changed. And I was part of a group called Pelvic Floor Sexual Medicine. We haven't had any of those meetings since the pandemic, but back then it was many of the physical therapists, pelvic therapists in Southern California. We'd meet with sexual medicine doctors, so San Diego sexual medicine, and we'd have different topics and we'd have speakers at topics. And it was just really fun, really way to like get together, network, and maybe learn something new. And a flyer went out, like a paper flyer that said neurogenic pelvic pain. And I was like, oh, this is what I have. This is the first thing. This is me. This is me. I have to get down there. Oh, but I can't drive 2.5 hours from LA. What am I going to do? So my friend May, who also was a pelvic PT, she's at Cedars. she's like, I'll drive you. And I was like, oh, so I was the passenger, and I was just like, and I got there, and then I was like, I can't sit down, and I'm in the back and I'm fidgeting. Like, what shoes do I wear? I have to look professional. Yeah, so they had a room at Alvarado Hospital, and Dr. Goldstein spoke, and they brought up the spine, and
Irwin Goldstein. He's
Erwin
the godfather of sexual medicine, as we always call him in Ishwish. He's
Goldstein.
actually one of the founding or the founding member of Ishwish, I think, the International Society for the Study of Women's Sexual Health. But go ahead.
So even though I hadn't really ever told anyone my story, and I hadn't told any doctors about my story, um I mean, I was so lucky because he was the first person who was like, oh yeah, I know that, I know exactly what you're
Yeah,
talking about. so
yeah,
so I mean, if
and
anyone would know,
I
or
mean that
it
is
would
so
be him.
lucky, actually. Yeah, I
I
mean
am
because
so lucky. I
he
really
is
feel
the
like,
PGAD man, right? Like
yeah,
he's
I feel
yeah.
like it was meant to be. Like, I'm here in this
Hmm.
state. I'm not from California. I live here. I got the flyer. I could have not seen the flyer. It was a paper flyer I saw. Like, it wasn't even an email back then.
Oh, right.
And so this was 2017. I get there. I think at that point they'd only had a couple people who had actually had surgery, and it was him and Chol Kim, and they talked about it. And I was like, I know these nerve pathways, like I did all this already, and I'm learning it. And I'm like, this is me. This story is me. They had someone in their office who also had PGAD, who maybe found him for this reason, but she also had the surgery, and I just connected. I went up to him at the end of the day, and I tapped him on the shoulder, and he tells it too. I tapped him on the shoulder. He turned around, and I was like, I have this. I have PGAD, and um, I think it's coming from my back, and I'm going to call you tomorrow. And I did. I called him the next day. Um,
You stayed in
I
San
had
Diego that night,
Yeah, I stayed in San Diego.
or
No,
did you?
no, my friend
Yeah.
drove me back. That was brutal. Yeah.
Okay.
Yeah, but the
Okay.
2 days
That's too
later, I
bad.
mean, that would have been so great if I could have just gone to his office the next day. I don't know why I didn't
The
think
next
of
day.
that.
Yeah, that's
I
true.
should have just
But
begged him, and
but
he
people
probably
have
would have let me
schedules. Yeah,
come.
he would have let you come probably.
He would
Yeah,
have let me
yeah,
come, but I didn't even think of it. Like, I do feel
yeah.
like I was constantly in a sympathetic state for at least
Oh
2
yeah,
years before this. Like
yeah.
I didn't even think of that because I was just like trying to survive every
Survival.
day. I was trying to get through the
Mm,
day every day. 2 little
mm-hmm,
kids, responsibilities, a job,
mm-hmm,
which I know I'm jumping around, but like I used to work 4 to 5 days a week, and I
mm-hmm.
was down to 1 day a week at that point. I was working on
Wow.
Fridays, and then
Uh-huh.
Saturday, Sunday, Monday, Tuesday, Wednesday, I would be recovering. Like, what
Recovering.
kind of
Oh
life is
wow.
that? I had no
Yeah,
joy. I was just
yeah,
recovering to work one day. Like, that is not
yeah,
living. And
yeah.
and so here I was, I tap him on the shoulder, I call him the next day. We do our little 10-minute call. He schedules me. I go down there, have the
You
neurogenital
had already
testing.
had your MRI at that point?
Oh, no, no. No,
No.
no, no, no,
Okay.
no. So
Right.
you're right. That was the first
Yeah.
thing. So we
Okay.
called them. They sent me, they're like, here, I had the order
Mm-hmm.
for the MRI when you have to have the x-ray for insurance in order to get the
Right.
MRI.
Yeah.
So I went to this physiatrist doctor, spine doctor that I knew that I'd taken my kids to, I've referred
Uh-huh.
patients to. So again, it was that like
Yeah.
really vulnerable state.
Yeah.
And I was really happy I got the PA, who's a woman, and she was the one
Yeah.
that was like, "Isn't this from birth?" And I was like, "No," but I was really embarrassed. And then I was like, "I'm not. I don't even care." I was like, "It hurts in my butthole. It hurts here. It hurts here. It hurts all." And they're like, "Yeah, this doesn't make any sense." And they tell me it doesn't make any sense. And she's like, "I thought your disc problems would be more like S1, S2." And she's like, "Yours is at L4. That's not the right dermatome. That doesn't make sense." And I'm like, well, it's happening, and this is I'm sorry, and it's happening, and so I was like, I just need the MRI. So I got the MRI. They read the MRI, and I did have a pretty like significant. Uh, it just depends who you talk to. Like, with spine, it's like someone you can have, hundreds of patients who have terrible looking MRIs but have no symptoms, right? And then you have ones that just have like tiny little tears that are really symptomatic. And so I actually had a pretty good, like, I had a lot of, I have a lot of wear and tear arthritis type symptoms in
Yeah.
my back. Like, I have
Yeah.
the arthropathy at my joints. I have all that, but L4-5, definitely a pretty big disc protrusion, like fecal sac, and It actually said nothing looked affected on my nerve root, but it
Yeah.
was. And
Yeah.
it
Was there an
definitely,
annular tear? I
I
can't
did have an
remember.
annular tear. I did have an annular tear. It
Okay.
wasn't like it didn't say the disc was impinging on the nerve root. So I did have an annular tear. And, that fluid, as you know, can just leak in onto the cauda equina, and you can get all kinds of symptoms. Like, I also had bladder symptoms. That was like something else. Like, I had urgency, frequency pain that didn't start till after my second C-section. So I was like, is it my C-section scar? My pelvic floor did sort of change, but I never really had like real like pelvic floor dysfunction. I had areas in my vagina, like on my pelvic floor, that maybe were more like connective tissue restrictions, but like not a real like tense, tight pelvic floor. I could contract, I could relax, I could lengthen.
So, just for the listeners, when we think about our vertebrae and our spine, we have, your cervical spine, which are the your backbone, basically from, from your neck down. Then you have your thoracic spine, which is that middle portion. Then you have your lumbar, which is your lower back, and then you have your sacrum. So, in between your vertebrae, which is your backbone, you have a cushion, and that's what the disc is, right? When people say they slipped a disc or they herniated a disc, that means at some point with some movement or some activity, something happened that propelled the disc to move in one direction, and those nerves that they traverse through that canal, into the foramen and all that stuff, and so you can get that. And then I think within each disc, you have an annulus and a nucleus. And so if you have a tear within that, it can then, their cerebral spinal fluid can seep all the way down into the lower spine, as well as, like you said, the cauda equina. So just for listeners that maybe don't have too much background in the spine, which can be a lot of people, because I don't think,
I think there's more people like, once the spine was really on my radar for this potential symptoms of pudendal neuralgia, and just like really any pain, like bladder pain, urethral stuff. Like, obviously you have, there could be hormonal, it could be, like you said, the end organ. Like,
Mhm.
I've had patients who have like 4 or 5 different potential contributors, and you just have to kind of like chip
Yes,
away and
treat
and
each one.
treat each one
Right.
and see.
Yeah.
Um, but like
Like
there,
Rachel Rubin says, we're sex detectives and
yes,
issuists, right?
yeah,
Because you actually have to like
you
take each
are.
region and,
Yeah, you
you
have to
totally have
test
to
each
do that.
region. And musculoskeletal wise, there's so many different contributors to the pelvic floor. And I know, region 2 is pelvic floor, but like, I find a lot of restriction in all my patients with PGAD in their abdominal wall. And, your clitoris
Mm.
attaches to your abdominal wall. It blends
Right.
into your abdominal wall. So a
Right.
lot of, and the guarding that happens. So a lot of the, just even the fascia within the abdominal pelvic cavity that we can treat as physical therapists, that can relieve a lot of my patient's symptoms. And I like
Oh,
to
that's
have that
amazing.
area really clear. And it doesn't
Mhm.
always have to be pelvic floor. It doesn't,
Like
there
internal
can
work,
be
right?
other musculoskeletal contributors as well.
Actual pathology that they found
Yeah,
on your
so I
MRI.
did have I had I looked over my MRI recently. It's been a while, and I was like, "Oh, I didn't
Mhm.
realize that's such a big disc herniation." I did have a herniation, but it was the
Uh-huh.
annular tear that was causing that disc fluid to come out and just leak, onto cauda equina. So,
Yeah.
um I had this. So first they set me up with an injection. Once they saw the pathology on the MRI report, on the MRI, I had an injection targeted. It was a diagnostic injection. I had steroid in it as well, and that was at L45. They were targeting that space for the nerve root to see if indeed that was causing my symptoms. And oh my goodness, like, I it took a couple days for the to kick in for me because I had more of a steroid based block. Um, I don't think that's what actually Dr. Kim ordered, but that's what they gave me.
That's
Um,
what all the I'll tell you a
yeah.
story in a minute, but my husband's interventional pain, and they always put
Yes,
a little steroid there.
a little steroid in there. And I and
Yeah.
and and I was very appreciative. I mean, that is what sealed the deal for me. Like,
Yeah.
I remember So you're supposed to go home when it kicks in, and you're supposed to do the things that cause you your symptoms, which can be really traumatic for my patients. Like, they're like, I don't want to, like, because they have catastrophized, and they're like, these are the things I never do anymore. I don't do these things. And it's like, in order to find out if you are a candidate for this surgery, and like, that is where we need to treat, you have to do these things, right? Which can be definitely mentally challenging to put yourself in those positions again. And so we had sex in like the way that I haven't had in like 10 years. And I was like, we're going to do that position. Like, I'm a little bit more like research oriented in that way, where I'm like, okay, now we have to test it. It's time. Let's go.
Yeah.
And,
It's time to test it. Yeah,
so
exactly.
we tested
Very
it.
romantic.
Very romantic. I know. And that's sort of what had happened to our sex life, to be honest. Like, we just, there wasn't the intimacy was gone, because it was like, I need to do this before I go to work so I can get 20 minutes of relief. Thank you. Like, it wasn't, it was a tough time.
Was it only intercourse that relieved it, or could you have relief with masturbation, or was it both?
No. So that's what I was talking about. Like, my masturbation changed. Like, I could never use a vibrator.
Because you never clarify. Yeah, that's right.
Okay. It was too painful. A vibrator was always too painful. I always just use my hand, but now I can use vibrators. I love vibrators. I love all the sensations. I couldn't use that back then, because it would just, it was way too much for my nervous system. And I know some people with PGAD are fine with vibrators. I was not. There's no way that was coming near me. But I did actually, one of the things that relieved my symptoms, and I'm just letting you know in case this helps other people, but if I had any rectal work always helped me, but also if I put in like a rectal dilator, butt plug, whatever you want to call it, we're going to get into it. But when I used that, that was one of my ways where I would get relief. If I put one in my butt, I think it would slacken my vagina and actually like slacken the nerves, and I could get just like 75% relief. And I was like, great. Like, but obviously you can't live like that. Like, that was like 20 minutes of my day, and I get, but like, I would do little things to kind of get me through, but that was a big one. So yeah.
So it was basically, we think, the L4, L5 annular tear, not even anything below, nothing in the sacrum, no Tarlov cyst, anything like that.
No
yeah.
Tarlov
So it was
cyst.
actually.
Do
you remember the injury that caused it from college?
I was 19. I was playing soccer. I actually was having sex, and it was a sex injury. So,
okay.
But I was playing soccer at the same time. I was doing something like a Kama Sutra, like back bend position.
Oh, nice.
Sorry, for the viewers. Sorry, husband. This was before him. I was doing something, and I remember being like, "Ow!" I strained my back, and I remember my teammates were like, "Hi, you have a sex injury." I remember I couldn't run. I couldn't run in practice. I had to get therapy on my back. Like, I think that, but I already had back pain before that. Like, I think that just like tipped it again.
Exacerbated.
We're talking tipping points. That tipped me over the edge, and I had a real injury. I didn't have leg pain then. I did have weakness in my leg later on when things had progressed, and I was like really neural. Like, I mean, everything was neural. I had a positive straight leg raise. I had positive slump tests, all these like orthopedic screening tests for spinal disc dysfunction. I had all of them. I was like a clear disc case by the end. There was no question that my spine was discal. It was just like, how is this causing issues in your pelvis? And that's why I couldn't tell anyone, and I would lie. I'd be like, my back pain. Oh, my back pain. And it wasn't until I went into that therapist where I needed to. She's like, why do you need a pelvic MRI? You don't have, oh, well, I do have pelvic things. Well, that's not, and that was that whole circle of things. It was the pelvic MRI that I couldn't keep it from anyone anymore. I had to spill, I had to tell. And it was what I expected, but I was prepared for it, because I was like, I don't care anymore. I don't care if you think I'm crazy. I don't care if I need this done, because I have a team now behind me that's going to figure it out. And I don't care what you say. I'm gonna, I didn't say that to them, but that was the mentality in my head. I wanted, thank you so much. I wanted that MRI. I wanted to, make them want me to have it. But because they hold the power. They have the power. I don't have the power.
Yes. And I think this is one of the frustrating things as we as clinicians face, right? Is that when you're dealing with issues around sex and around sexual pain and genital pain, like it's never clear. Like insurances sometimes don't clear it, right? The
Yeah.
MRI is not, oh, that's not a straightforward reason to get an MRI. Like this happens to my patients all the time when I
Yeah.
order
All the
for
time.
PGAD. I'm like, okay, the major thing is PGAD, but can I say anything else? So then I'm like,
Yes.
just as a side story, my
Yeah.
husband's an interventional pain doctor. So he taught me spine once he started his practice in 2012. I started mine in 2014. He's like, let me teach you a little spine, because if you have patients that can benefit from me, then you can refer to me and vice versa. So I was like the
What a
only
team.
gynecologist in town that would like ask about the spine all the time, because we were
Mhm.
both trying to build our practices. And it was at one point within the first 2 years that we were married, like I was like, I have this patient with all these weird pelvic pain, but she also has like, a little bit
Mhm.
of sciatic stuff. And so
Yeah.
do you think if you treated her this, it would help that? He goes, well, let's try. And so we would go
Ah,
through and do some of that
yeah.
actually. And so that's why like I always like, was like, oh, the spine is, and then I would see it at IPPS. Eventually, like some interventional pain doctors started coming, and I
Right.
thought that was very interesting that
Right.
the connection between the spine and the pelvis became real. But my point
Mhm.
really is that, okay, we have people that believe in this, right? And that they're
Mhm.
able to do it, but insurances sometimes don't buy into it. So it's out of pocket cost for patients.
Exactly.
And then if you do find somebody that's willing to do the injection, right? Like I can just send my patients to him and he'll
Mhm.
inject them. The next roadblock that we find, at least in this area, is like, what surgeon's going to do that procedure because you have sexual stuff happening, right?
Right. Right.
This is the big inhibitor. I
Mhm.
mean, you're lucky that you were in this San Diego Sexual Medicine Center
I know.
where they were studying it. But,
Mhm.
I've had to send my patients to like Texas and other places that, oh,
Right.
this patient had a very big Tarlov cyst. I diagnosed
Mhm.
because she had all this vulvar stuff. She ended
Yeah.
up in Texas,
Yeah,
like,
there's a specialist in Texas. Yeah.
yeah, he's amazing.
So, I
Yeah.
mean, I definitely now, like, I mean, I always screen the spine anyway, and I
Right.
think most PTs should be treating the
Screening.
spine because it affects the pelvis, but it's
Right.
definitely changed. Like, I'll have someone come in who I had a male, that comes to mind who had been having pudendal, like, symptoms for years, um, and some other sexual functions, issues, and, um he was getting like cortisone injections all the time in his back, but he was doing all the things that would make a back injury worse. And so I actually just said, we're going to treat your back. Like, so I'll have someone come in, and the way I change maybe how I'm going to do my treatment, you go like proximal to distal sometimes. And so I'll say, well, I'm going to treat you like a back patient today. And his symptoms went down. So we treat people with disc injuries all the time. And I think, um, it's really an appropriate place for us, and I mean, I think the question comes to by the time someone is suffering so bad and they're going to get when they figure out it's their back, how much can PT help at that point? And that's sort of like what we don't know. Like, I have one person who at one point, like, she had lichens, she had vestibulodynia, GSM, all the different contributors, as well as a spinal issue. And she did have positive neurogenital testing. She didn't want to do a surgery. She actually did okay just with PT. But that's what she wanted. She's like it wasn't, we got it in time. We got it in time. And there's nothing wrong with having a surgery. Like, if it's more invasive, but it's done so well. I mean, it's I wanted, like, I'd been doing PT for years. I was not going to get better with PT. There has to be that point where it's like, this isn't enough, or this isn't working. And I think most of the people that do get the surgery, just they're at that point, or they haven't even had their back treated because someone's been chasing their pelvic symptoms and they haven't even had their
Mm-hmm.
back treated.
Or
Um,
assessed. Yeah.
yeah,
Tell us
yeah.
now. So you had the surgery, and then how did it go after? So, okay, the block worked, right? So then you decided, let's go.
The block was blew my mind, because I
Mhm.
remember walking around and being like, my leg, like, I've had just constant symptoms for so
Throbbing in
long,
your leg
and
for
I
so
felt
long.
like my leg was like floating. It was like there was nothing.
That's
Talk about
amazing.
identity, because you sort of live with something, like, it's
Yeah.
part of you. even though you don't
Uh-huh.
want it to be part of you, it is part
Yeah.
of you. It's sort of part of your story, and then it isn't
Yeah.
anymore. And
Yeah.
it's really strange. Like, I'm so glad it's gone. And there's that little piece that's like, what is, it's wild. It's
Weird,
wild when
because
you
you
don't
don't
have it.
remember what it's like without it, right? That's what my
Yeah.
patients always say,
Yeah.
like, and you wonder, like, that's probably how the brain gets activated in some patients that get that
Yes.
phantom leg
Yes.
syndrome and all these centralized pain syndromes,
It's
right?
fascinating. And so
Mhm.
2 days later, gone. It did not last more
Amazing.
than 2 days. And
Oh,
I mean,
okay.
I think it just leaks out. I think I have
Yeah.
that tear, it just leaks out.
Yeah.
And I was like, sign me up. When can I get
Yes.
in? So I had my surgery May 17th of 2017.
Okay.
And it's a small, the one that Dr. Kim does, told Kim, it's minimally invasive, and
He's
it's
out of San
through
Diego, yeah.
an endoscope. And that's also why they target what side, because he's going to go in through the lateral foramen. Like, he's going to, instead of having that discectomy scar in your back where they actually have to cut through the muscle, he can
Mhm.
bypass the muscle and just go through your vertebra. They clean
Mhm.
that out, and
Mhm.
uses a laser to repair
Close
the
the
disc.
r
And so
Mhm.
um, I
Seal it up.
was particularly, I'd say, from the way I would describe it, as neural. Like, I had neural symptoms for very long. So soon
Mhm.
after the surgery, like right away after, I was like, oh boy, like, I had surgery. Where some people wake up and they're like, I feel great. It's almost like having that the shoulder surgeries that are done so well now, they have like very, no restrictions. I really had to restrict myself just because my pathway was very neural. But one of the things that I always tell people when I do a consult them with them for surgery, and so this gave me sort of peace of mind. Like, I knew it worked. I knew it worked right away because something was different. Okay, so the many, many symptoms I had, there were less of them. It was reduced. I just had what felt like, I can only imagine, like a gunshot to the back, because
Mhm.
everything was centralizing. Okay, so
Yeah.
in
Yeah.
physical therapy and ortho PT, we talk about peripheralization and centralization.
Mhm.
So if your disc, is getting, your symptoms are getting worse, the pain's going to start to go to your extremities. Your symptoms are
Right.
going to go
It's like
down. And when you think,
the nerves talk to each other, right? So they're
right,
talking
and
to
so
each other
when
at
you think
each
of
organs talk
PGAD,
to each other. Yeah.
yeah, you can think of it as like, that the same thing as having pain down your leg. I happen to have both, right? But it's, if your neural symptoms are getting worse, coming down to the extremities or going into your genitals, you need to back off. When it's worse in your spine, that's a good sign. Your back pain's worse, great. Less in your genitals, it's more in your back, that's a good sign. So I was really careful with, and movement's good, but I was very, like, I knew my body at that point, like, what makes me better, what makes me worse. I knew how to move. I knew how to transfer. I knew how to use my breath so that I wasn't like bearing down on your disc, like coughing, sneezing, all the things that would make you feel more discal and just irritate your nerves more. Um, and so I was really, just getting out of bed, just all the things. I walked every day, but I knew how to pace myself. And that again is something, like, when I work with their patients, even from out of state, I can just do a consult. I can just give some education and really try to set them up with a good physical therapist in their area that can treat ortho and pelvic, because I have an issue with people. Oh, well, it's my back. I'm just going to go to back PT. Well, you're not going to tell them you have PGAD. You're not going to tell them, like, how do they know if you're getting better? You're making your functional goals as a physical therapist. This person has back pain. Like, you're not going to say, oh, they're going to be able to have sex again. They're going to be able to have an orgasm again. They're going to not have pain into their genitals. Like, you have to be able to talk to your physical therapist to make appropriate goals. And also, having PGAD is like, it's traumatic, right? Just like having pain is traumatic, but there's something about having the arousal component. It depends on the person, but it can feel like you're being raped all the time, like constantly violated, constantly, just, you didn't ask for this. These are this is not a sensation I want. There's nothing pleasurable about it. You feel like you're being punished. You feel like it's grueling. You're in agony. Like, how are you going to go to a sports spine PT and tell them these things? I don't even know if they're familiar with how the nerves into the genitals. I mean, I wasn't until I studied it, until I went into pelvic health. So we need pelvic health therapists to be really good at ortho, really good at spine rehab, and be able to do both. And I try to be that liaison with education. I always offer, like, if I do a consult with someone, like, I help them find a PT. I give them a few options. I try to find them in their area. I go through my network. And then we usually have conversations, and like, I don't charge them. Like, I just talk. I mean, I charge for the consult because there's a little bit of extra work and time, but I do, I will be open to work with that PT at any point and just be part of that journey with them so that they can I really just want the best outcome because the surgery works. If you're a good candidate and they really screen you if you're a good candidate, I feel like the surgery works. It's just sometimes, the way the brain works with pain, and I'm not saying people mess up their surgery or anything, but it's just, we need the brain to know it's safe and it's okay. And if, like, you're constantly aggravating things and making things more inflamed, it's going to feel like it didn't work. If you're going back to some activities too soon, it's not like the tissue. These are people that have had that whole nerve pathway has been inflamed sometimes for a long time. A lot of compensation takes place, motor patterns change. Like, I didn't rotate my hip like, I didn't internally rotate my hip because it would just send it. And that may not make sense to someone. Why does hip internal rotation affect your genitals? I had a spine doctor say that to me. They're like, and I'm like, well, your sacral, your sciatic nerve goes right through your hip rotators. Your pudendal nerve passes right through there. And yeah, when I turn my hip, it gets tugged. It's like tight all the way down and it gets tugged. So even just like, this is something that you can't give someone necessarily a piriformis stretch with this. It's going to flare them. So yeah, so I that's sort of where I think having this and being who I am, I want to help people. This is like sort of, I mean, this is one of my purposes in life. This is I had this thing that is terrible and I wouldn't wish it on anybody. And I can do something with this, and I'd like to do more. I need to, get myself out there a little bit more. And because I do have, of course, I have my own ways of how I think people with PGAD should be treated and gone about. But it is like, you need someone who's trauma informed to work with you all the way through surgery. Surgery can be like the big missing piece of the puzzle, but it's the after is also important.
Right. Right.
So
It's kind of like when we do vestibulectomies for like congenital neuroproliferative or whatever, like
yeah.
you think, okay, I've removed the inciting factor, but now you have vaginismus and now you have this because
Mhm.
your
Yes.
response is that this is going to hurt.
Yeah.
And so you have to retrain everything. And so
Mhm.
it's that retraining that's so important too, because otherwise you think this is a failed surgery, which it's
Right.
not.
It's not
But you
failed.
have to do the
And
rehab and the
yep.
prehab are just as
Mhm.
important.
And the prehab's really important. That is one thing I'd like to figure out a little bit more. Like, I would love if we could get someone who's going to have surgery set up with a PT even a month before, not under the pretense of like, oh, they're not going to have surgery. No, like, let's do some prehab and let's figure out your body before so we can see after. It's also really fun to see the before and after. Like for
Absolutely.
instance, for
It's
me,
so cool.
like, when I could turn my hip again, like, it changed how I walked. I had so many compensatory strategies to do things, and
Yeah.
like aches and pains in all these places. And
Yeah.
even through my leg, I did have true radiculopathy. And like, for years, I couldn't plantar flex. Like, if this were my ankle, I couldn't do this or this. I
Mhm.
didn't have drop foot. I could plantar flex, but I was making up for it with other muscles in my body. And I always had like
Right.
spasms and cramps. And
Yeah.
all of a sudden, 2 weeks out of surgery, I could do this motion. It freed my nerve. So it was just, I had orthotics for like 20 years. I didn't need them anymore because my foot actually started to pronate. Like, all these little things that, if your physical therapist can assess you before, and I'm not talking like even pelvic floor, I'm talking muscular, like, it doesn't have to be internal. And internal work does have its place and it is important depending what's going on. But I think just so listeners know, like if you have PGAD, and I think a lot of women are afraid to go to physical therapy because they assume like, oh, I don't want to have an internal exam, or what if I have a orgasm, or what if I have a worse episode, or what if I flare? Ideally, there's always informed consent, but I want them to know. I mean, there's always informed consent, but like none of these things are have tos, right? So we have a menu of things we can do the first day, and it doesn't have to be a pelvic exam. And, even if someone's like, oh, yeah, I consent to that, like just do it. But, like their body language is telling you otherwise, like that is not appropriate. Like we don't do pelvic exams. I very rarely do a pelvic floor exam the first day, or like I'm going to be like, I'm going to look at your clitoris. Like, they don't want you anywhere near their clitoris. They're not comfortable with that. And that's okay. Because this is the thing, you can flare from many different contributors, right? You can think about flaring and flare. You can be anxious about going to PT and flare. No one can touch you and you can flare. So you want to establish that therapeutic relationship of trust, and like, we're going to go slow. We're going to check these things out. What can we do from the outside today? There are so many things we can do externally that don't involve your pelvic floor that can have a relationship on your nervous system, on your pelvic floor. So like you can start anywhere, but your PT really should be like your ally, like your investigator, right? Like your detective. And it's a team effort to figure things out. Like you might have triggers that you don't even know you have, or you
That make your
might think of
anxiety worse,
something.
or getting treated your anxiety, all
Yes.
these things.
Or
So that's
even
why
just like
sex med is
mechanical,
biopsychosocial.
biopsychosocial, even just mechanical, like
Yeah.
you're doing certain activities. Okay. So like a lot of people, they're with PGAD, their main way they manage is distraction. So think about, you're basically going out of your body. You are distracting yourself with all these things so that you can survive the day. And it's such a catch-22 because we want to bring you in your body, we want you present, but at the same time your body's not a safe place to be. So it's really challenging, but they need to be aware of like, this thing makes me worse, and they may not know it makes them worse. So if we can pick up on these, mechanical assessments, screen for spine, screen for neural tension, um, like you said before, it's not cookie cutter medicine, it's not cookie cutter physical therapy. And figuring that out gives you tools to reduce symptoms. So even if you're not going to be fixed by physical therapy, you may not be, usually it's a lot of things at once, that there's a lot of things that need to be treated. But it's same with pudendal neuralgia. I mean, you could have PGAB because you also have pudendal neuralgia. Um, you need to figure that out for yourself. And it's very individual, which is why, like, when I see people being like, do this stretch for PGAD, I'm like, come on, like you, like that's not okay. It's not okay. And so I want people suffering with this to know that like, your PT is supposed, and if you don't get a good vibe from your PT, that's not your PT. Like, it's you got to have that, and not every person is for every person. And you should never
Same
feel
with your
like
sex med doctor, your clinician, your
everything.
psychologist, your sex
Your
therapist,
hairdresser,
whoever's helping. Your hairdresser. Exactly.
anyone,
Yeah.
anyone,
Yeah.
and so recreating, like getting those motor patterns back post-op is really important. And I think, like you said, the prehab, like I love that you said prehab, because we get prehab for ACL surgery.
Mhm.
You get prehab for back surgery. Most people that go in for back
Mhm.
surgery, they've failed, or I hate the word fail, but like they did their course of physical therapy. It wasn't
Yes.
enough. They needed
Yes.
surgery. So it's like
Yes.
surgery is usually the last resort. And I
Right.
think sometimes these patients with PGAD, they've just been through hell and back. It's like, do
Right.
it, get it done, especially if the
Yeah.
injection works. But it can be challenging working with
The
them in
post.
post-op,
Mhm.
because they haven't had that figuring out phase, really
Mhm.
hasn't been established for them.
Right.
Um,
Right.
so
Well,
yeah.
April, a definite amazing physical therapist, and she is a fierce advocate for PGAD, as she has struggled, for so many years with it, and is now PGAD free, which is
Yeah.
the beautiful part of the story, is that she is free of these symptoms. As many of you, if you have suffered from this, you can also get there. You just, the right team has to be involved, and you have to advocate for yourself. So hopefully this episode gave you a little bit of education so that you can advocate.
I think that there's so much information more now that we have out there.
Right.
That
comparatively. Right.
I don't know what I would have done differently, because I don't think I could have handled the gaslighting.
Los Angeles. I'm going to put in the description how you can, get in touch with her if you need to see her for consultation or other things.
Yeah. You can reach me through my website.
Yeah. You want to repeat your website for us?
Oh, it's wholebodyla.com. One word.
So that's WHOLE, whole.
Yeah. Yeah. WHOLEBODYLA.com. And you can just send me a message through there, and I'll get back to you in a day or two at the most. Usually I get back right away. And we can do, I offer a 10-minute free just phone call anyway, even before I take someone on as a patient. So I'm happy to do a call with you too. It's just, I have to kind of keep it at the 10-minute mark. If we want to do something longer, I do charge a consult fee.
Of course.
Yeah. But I can help you find your team.
Your PT as well, your team.
Yeah.
And also www.isswsh.org is the ISWISH organization website. The patient-facing website for ISWISH is Prosayla, Prosayla. And more information on PGAD. I think the main organization that deals with it is ISWISH. So, well, thank you again, April. Your story is so compelling. The work that you do is so compelling. I do believe that, that I do have a feeling that God gives us things that, we can handle so that we can further, benefit
I feel
others.
the same way. Yeah.
And I do feel like your suffering was not for nothing, because you've made such a difference in so many people's lives at this point. And hopefully people listening will, reach out to you, or, get some bits of information they can take back to their clinician, whoever's taking care of them. But I appreciate everything that you do.
Thank you so much, Samina. Likewise. And really, it's an honor. Thank you for reaching out. And I'm going
to have you on again so we can just talk about some general PT stuff and everything.
Fantastic.
How you treat, maybe, but I feel like, we wanted to touch on the story of PGAD today, but once we get going with the podcast, I'll have you on again.
Thank you so much.
All right.
Okay.
Yeah, of course. All right, hon. Thanks again. I appreciate it. I'm going to stop.